Hi, and welcome back to the second part of my capstone and service series. Today, we're going to talk a little bit more about cancer pain, kind of introducing things to know about cancer itself, as well as talking about cancer assessment, comprehensive pain assessments, and then I'll introduce some intervention strategies today. Same disclaimer from the last presentation. Please always use your best clinical judgment when applying any of these assessment or intervention strategies with your own patients in clinical practice. This is just a look at today's objectives, what I'm hoping that you will take away from this presentation. But just to jump in and introduce cancer a little bit, some key statistics that I wanted to provide for each of you. Some of it I have introduced already, but wanted to reintroduce and reemphasize. As I mentioned in the last presentation, we are looking at an increase of people who are living longer with and beyond cancer. We're looking to expect about a 12 million person increase in cancer survivors by the year 2040. Most of these are going to be people who are over the age of 65. This is what's being called the silver tsunami. And with all of these cancer survivors becoming more common and likely being in the older adult population, we can expect that a lot of cancer survivors are going to go through inpatient rehab at some point. Looking specifically at adult and older adult cancer survivors, a little over half of those who were diagnosed with cancer as an adult are going to report some kind of functional limitation. Beyond that, up to 70% of cancer survivors are going to report some level of assistance needs with their activities of daily living or just general daily activities. Also, kind of within this sphere, about a third of cancer survivors who receive some kind of cancer treatment are going to report three or more ADL symptoms or moderate to severe impairments that are going to affect their performance in ADLs. And these numbers are going to be higher for those who are survivors of later stage or more advanced cancers or those who received multiple treatments. Thinking about those who are stage 3 and 4, those with metastatic disease, and those with either disease recurrence or more aggressive treatment methods. I ran across this quote while I was putting these materials together and just kind of as I've been learning more about this topic. And I think that it summed up kind of the common conversations in oncology rehab right now. The quote is, in effect, the medical system creates a situation where high functioning individuals are given life prolonging treatments and then left to struggle with how to recover from toxic adverse effects. The conversation for so many years has been, how do we cure cancer? How do we help people live longer, either with or beyond cancer? And now that conversation is changing to, a lot of mortality rates for the common cancers have decreased significantly. And now we have all of these cancer survivors. How are we going to help them live well and live good lives and have quality of life? To briefly introduce some common terminology in the world of oncology, some of these terms you may have seen before. Also, going to hopefully see. Looks like I can't move my. Okay. Looking at some common terminology in the world of oncology, I know my face is covering up one of the terms. So, for discussions of the different levels for metastases, I do have a copy of my slides that are available for you all as well. I want to talk a little bit about the different types of staging. You'll see these in documentation depending on how relevant they are for the setting. The type of staging that likely most of you are going to be familiar with is the numerical staging. To introduce TNM staging first, though, TNM staging is a measurement tool that measures the tumors, nodes, and presence of metastasis. If there is an X, so it's going to be T number, N number, M number. If there's an X, that means that there is some kind of presence, but it can't be measured. An O means there is no presence. And then for tumors and nodes, we're going to see a number scale of either 1 to 4 or 1 to 3. This is going to be an increasing scale. So the higher the number, either the larger or um, the higher extent of spread or involvement is going to be associated with higher numbers. Metastasis is only going to be an X, a 0, or a 1. 0 meaning that cancer has not spread to other parts of the body, and 1 meaning that metastatic disease is present or cancer has spread to other types of the body. Numerical staging is going to function similarly, where the least involvement is going to be either stage 0 or stage A, and metastatic disease or the highest level of spread is going to be stage 4, which is going to be our latest stage. Some other common terms you might run into are locational terms, just again looking at if and where tumors have spread. In situ meaning that cells are near the primary tumor, all the way to distant where cancer has spread to further parts of the body. Now, looking at some common treatments, first line of defense for cancer typically is going to be surgery, where depending on the location and the size of the tumor and truly the goals of the individual patient, the surgeon is going to go resect either part or all of a tumor or cancerous tissue. This can be to remove as much as possible, to debulk it or make the tumor smaller in conjunction with other treatments, or just to make the patient comfortable, decreasing the size of the tumor to decrease pain or other functional impairments. Some of considerations for surgery that we want to make as therapists are what was removed and or moved around. If bone was removed, if muscle or nerves were sacrificed or moved to other parts of the body, if the brain was impacted, or if lymph nodes were removed, are all things we want to know. Otherwise, a lot of considerations and side effects are going to follow the same pathways as other surgical procedures, where it's important to know any range of motion, lifting, weight bearing precautions, and what the prognosis is, what the surgeon believes is their functional potential, and what the overall goals for rehabilitation are. Moving to the next one, chemotherapy is another common treatment that is going to use medication to stop the spread of cancer, either by killing the cells themselves or by stopping their division. Kind of a caveat with this is that chemotherapy drugs are not only going to kill cancer cells, they're also going to kill other cells in the body as well. Chemotherapy can be used across the cancer care continuum, either to treat primary cancer, disease recurrence, or metastatic cancer. And it can be done before surgery and radiation or after as well. Chemotherapy is going to be administered by a few different routes, either by mouth, injection, infusion, or topically, so through the skin. Some common side effects on the acute side, when someone is in active treatment, we'll see immune system suppression, fatigue is really common, cognitive impairment. If you've heard the term chemo fog or chemo brain, that's kind of what we're speaking to. Depending on the route of administration, we're also going to see sores in the mouth and the throat, especially if it is administered by mouth, GI distress, and nausea, vomiting. Long term, some subacute and chronic effects are going to be hair loss or alopecia, soft tissue fibrosis, cardiopulmonary toxicity is caused depending on the drug that's used. So we will see some cardiopulmonary changes for those who have received chemotherapy at some point. And then chemotherapy-induced peripheral neuropathy, or CIPN, which is going to be damage to the peripheral nerves caused by the chemotherapy drug. For radiation, primary goal of radiation is to damage the cellular DNA of a cancer cell or tumor so that it can be broken down and removed by the body. Big note with this is that this isn't something that's going to happen immediately. Oftentimes, it's going to take several rounds of radiation in order for the DNA to be broken down enough so that the body can break it down. The reason this is important is often side effects for radiation are going to be a little bit delayed in onset compared to other types of therapies. Radiation can be administered either externally or internally, and side effects are going to change a little bit depending on which route of administration is used. Some of them are going to be similar to chemotherapy with the immune suppression, alopecia, and fatigue. Some other more unique ones, though, for external beam radiation, we're often going to see skin irritation and soft tissue fibrosis. Irritation, particularly in the area where the cancer is and where the radiation beam is being applied. We may also see plexopathies and neuropathies depending on the location of the radiation, as well as some inflammation and a potential for bone loss and necrosis at the joints. The final common therapy is going to be hormone therapy, which is typically used for either reproductive or more hormonally driven cancers. It's most often used in the treatment of breast and prostate cancer. It's used at different points across the care continuum for different goals. The goal primarily is to reduce the level of hormone. If it is done before surgery, the goal typically is to make the tumor smaller before surgery and radiation to decrease the amount of tumor that needs to be removed or the amount of radiation that needs to be applied. If it's done after, kind of at the end of treatment, often it's used to decrease the risk of disease recurrence. The side effects for the use of hormone therapy are really going to mimic that of changes in hormones. The best example is with breast cancer. A lot of breast cancer survivors who receive hormone therapy will have similar symptoms to menopause. Looking at osteoporosis, fatigue, weight gain, and depression can also be really common, and anemia as well. These effects can be a little bit more long term, and can last up to several years after treatment is concluded. When I'm talking about the cancer care continuum or the survivorship continuum, this is what I'm talking about. When someone receives a cancer diagnosis, they enter what's called the survivorship continuum, which is going to spread for the remainder of their life through pre-treatment before they have really started any treatment, while they're in active treatment, receiving either any of those interventions I've previously talked about, in remission or maintaining, preventing recurrence of disease, all the way to the end of life if they are receiving hospice care. Some common late effects, like I've said, now that we're transitioning into people living longer with and beyond cancer, we're going to see some interesting long term effects depending on the type of tumor, how or what stage they were, what treatments they received, et cetera, et cetera. Some common late effects are going to be this list here that we will probably see in inpatient rehab fairly often. We already are seeing a lot of this. Cardiovascular, a lot of cancer survivors are going to be at higher risk for heart failure, especially heart failure with decreased ejection fraction. Cancer survivors also are going to have a 10 to 12% risk of a cardiac event up to a decade after treatment. Depending on their unique case, we're also going to see some pulmonary involvement, musculoskeletal, and neurological involvement as well. For just kind of as a general population, cancer survivors are at a 25 to 30% higher risk of experiencing falls in older adulthood. This can be caused by a few different reasons, but some common reasons are a loss of proprioceptive input, a loss of sensation for those with CIPN or radiation induced peripheral neuropathy, and then just a general loss of strength and muscle mass, either due to aging or again due to the specific circumstances of the survivor's cancer journey. There's also going to be a lot of psychological considerations for this population. Cancer survivors report higher rates of fear, anxiety, and depression, and almost 18% of cancer survivors will be diagnosed with depression in the long term. Why do I bring all of this up though? There are going to be some significant implications for therapy. I've listed some factors to consider here, but all of these factors, including factors that I've already talked about in this presentation, are going to impact how we design, plan, and execute our goals and our treatment sessions. For those who are in active treatment, it can be helpful to know a lot of these things so we can plan accordingly, because they are going to impact our treatment sessions. A lot of cancer survivors who are receiving chemotherapy will report feeling awful either after their treatment session or even the day after. So, knowing that can help us to not plan super physical sessions the day after chemotherapy, because that's just not realistic. Moving now into assessment and intervention, I'm going to cover assessment in more detail today, and then my following two sessions are going to be really focused on interventions. This is the biopsychosocial model on the left side of the screen. This is the most widely accepted model for evaluating and really looking at chronic pain. I want to introduce, though, a new version of this model that just came out a couple of years ago, that's added a fourth domain of spirituality to this model. In the patients that I've seen at Encompass while I've been here for Capstone, spirituality has come up a lot, whether through a relationship with organized religion or personal spirituality. This kind of connection with either a higher power or the higher self has been something that has come up with almost every survivor that I've worked with here on site. So, if you're using this model, I would highly recommend the biopsychosocial spiritual model over the traditional biopsychosocial model. Parts of a comprehensive pain assessment, we're going to look at interviews, assessments, and observation. The interview, the best recommendation is to use what's called the OPQRSTU method. This is just a guide for an interview, looking at O, meaning onset, provocation, palliation, what makes it worse or better, what does it feel like is quality, where is it, and does it radiate or stay in the same place is R. Severity is going to be your pain number or category. The time, either you can talk with onset, either when did it start or how long has it been happening, but you can also talk about times of day where it's worse or better. And then understanding, either understanding where the pain came from or understanding of basic pathways of pain, understanding of coping strategies and the importance of physical activity, etc. If you need to do an additional assessment beyond our basic FACES pain scale, numerical rating scale, or visual analog scale, my greatest recommendation is to make sure you're using a scale that is validated for your patient's diagnosis. For pain specifically, the best recommendation, and both of these tools are going to be in the toolkit at Encompass if you ever find yourself wanting to use them. They are both free, so you can just make a copy and use them. The gold standard is the brief pain inventory short form. I like this one because it gives you your number severity, but it also talks about different parts of the person's life and how their pain might be affecting their life. It can really open up room for a conversation, but also show where maybe we need to provide intervention. The Abbey Pain Scale was originally created for dementia, but it is now validated for advanced stage cancers for those who may not be able to communicate. It's an observation-based scale, but it is very helpful for different behaviors that might be or a little atypical from the norm. Last thing with observation, if the patient is able to communicate their pain, observation should always be secondary to patient report. But I also want to introduce some cultural considerations, because different generations and different cultures are going to view pain very differently. There are, depending on the culture, different beliefs on where pain comes from, different beliefs on how pain should be reported, if it should even be reported, and what should be done about pain. Again, if anything should be done about pain. So being aware of those different cultural considerations. Again, I have a list of like common beliefs surrounding pain for common cultures that are seen here at Encompass in the toolkit in case you ever need to reference. For those who may not feel super comfortable talking about pain, you can also listen for words like aches or soreness or discomfort, a lot of those words mean similar things to pain for those who don't feel super comfortable talking specifically about pain. Moving into interventions now, these are the rehabilitation stages for cancer. Rehab can occur at any of these stages. Most often, though, we're going to be living in the restorative, supportive, and palliative categories, either helping to return to previous level of function or accommodating for existing decline and existing needs. Like I said, I'm going to introduce some interventions today, but in my next two presentations, I'm going to go in detail about different types of interventions. For cancer specifically, the top three interventions that are recommended across the board are exercise and physical activity, lifestyle changes and behavior modifications, and education. These are like the gold standard. If you can only pick a small set of interventions to use, these are what is recommended to focus on. I want to touch on physical interventions for cancer specifically, and then we will be just about done with this presentation. The recommendations for physical activity is going to change depending on where the survivor is at in treatment. For those um, who are in active treatment, the recommendation is to use rate of perceived exertion. These numbers are based off of the Borg scale. So for those who are able to tolerate, the recommendation is moderate intensity exercise 2 to 3 times a week, looking at a rate of perceived exertion between 12 and 16. For those who are either significantly deconditioned, have really low activity tolerance, or report a lot of distress, shifting that down to lower intensity, at least 3 times a week, ideally more, and at a rate of perceived exertion of 7 to 12 is recommended, at least until you can get up to that moderate level of activity. The goal here is focusing on energy conservation and modifying behaviors. There's a lot of evidence that supports that sedentary behavior before diagnosis and during active treatment is typically associated with higher rates of mortality and worse outcomes, whereas those who are more active before diagnosis or those who become active during active treatment tend to report less severe side effects to the treatment, have better outcomes in the long term, and have decreased rates of mortality. For those who have entered remission or who are maintaining, the main goal is to either maintain or restore mobility to improve cardiac function, especially since we've talked about how cardiopulmonary effects are going to be really common for those who received especially chemo and radiation therapies, and either maintain or restore physical activity levels. Recommendations are going to be very similar to physical activity recommendations for any adult. Moderate intensity exercise for about 150 minutes a week. Looking at moderate, hopefully 2 to 3 times a week, and then lower intensity as needed. Putting a focus on weight bearing and resistive exercise, especially for those who may be experiencing osteoporosis or bone loss, is also highly recommended. These are just some other common physical interventions that are recommended. Um, Sensory desensitization and the use of the TENS unit are recommended specifically for neuropathic pain, especially for those who experience allodynia or pain to sensations that really shouldn't be painful. Sensory desensitization can mimic that the same methods that you would use for post-stroke recovery for those who may experience allodynia in the affected limb. The last things here are going to be psychosocial interventions and self-management. These are the top two things that I'm going to be talking about in the next presentation, looking at lifestyle modifications, behavior modification, building coping skills and self-advocacy skills, and then patient education and mental health interventions are also very, very helpful. If exercise is number one, these are our number two intervention strategies. And then the last thing here is going to be ADL, IDL interventions and fall prevention. These are going to mimic those that you would already be doing with any older adult with some functional disability. Specifically for those with neuropathy, emphasizing safety evaluations, teaching skin checks, the same thing you would do with like diabetic neuropathy or any kind of sensory loss is recommended. And again, we'll talk about these all in the next two presentations in more detail. These are my references. Thank you all again so much for coming. Again, for my virtual viewers, if you're interested in being involved in the Amazon gift card giveaway, this is the same link. If you'll just fill out that you completed this presentation and what you took away, I would greatly appreciate it. Otherwise, that is all I have. Hopefully, I will see you in the next presentation. Thank you.